Hey everybody, welcome to Ask Dr. Testosterone, starring Dr. George Touliatos over in Athens, Greece. And today we have a very, very special guest. If you watch Jay Cutler TV on YouTube, you probably know this man already. He is Dr. Rand Mcclain, owner and operator of Regenerative and Sports Medicine. And he's joining us right now all the way from Los Angeles, California. Welcome, Dr. Mcclain. Welcome to the show.
Thanks for having me. Pleasure.
Hello. Thank you for being here. And I mean, 3 years ago, actually, was October 2018. I was a guest in your show, and now I have to pay back this gesture, you know? So it's good to have you here. And I acknowledge a lot of your contribution to the fitness society. We share the same passion about bodybuilding and anti-aging. I have to tell you that I'm a fan of yours many years ago. And you look pretty good, in great shape for your age, you know? And okay, let's start rock and roll.
Thanks, Doc. Again, my pleasure to be here anytime. It's always a pleasure. And yeah, you remind me of, I know you're being nice to me, and I appreciate that. It reminds me of a story when I finally realized I was old, you know, going through the checkout lane, and the girl says, excuse me, sir, do you mind if I ask your age? And I told her my age. I think it was in my 40s at the time. She says, you know, I'm thinking, hey, I'm getting some attention from you, cute girl. She goes, I sure hope my boyfriend looks as good as you do when he's your age. I know you meant well, honey, but you just, you know, completely ruined it.
It's just a number.
I'm too old, obviously. Anyway.
Dr. Mcclain, I'm curious this year, how do you fit into this whole bodybuilding and fitness industry? Did you compete yourself at one time too?
You know, contrary to what a lot of people believe, and I guess it's just because I've always been in the gym for so many reasons. I've never been a bodybuilder per se. I've never been a competitive bodybuilder. But of course, I love building the physique. I mean, who didn't want to grow up to look like Steve Reeves? Whoever watched, you know, Tarzan thought, you know, wow, that guy's built really well. And so I honestly, since I'm 11, with the old plastic covered sand weights, you know, I started working out, and it's been a great way, I always say, for both mentally and physically to stay in good shape, you know. So, no, I've never been a bodybuilder. But of course, I got the pleasure of training at the Mecca Gold's Gym for the longest time. They're actually coming back now. They've reopened, you know, partially reopened recently. But I met so many great bodybuilders along the way, and trainers of great bodybuilders. So, you know, it's been a passion to help out and to learn. You know, Doc, I'm sure you learn from some of your own bodybuilder patients. You can go and look at the literature, but they're not doing the kind of testing, if you will. And I don't mean that in necessarily a derogatory sense, like they do in the gym, right? Guys will put things to the test. These are athletes, and there's no cutting corners. There's no ifs, ands, or buts. Something either works, a certain training regimen, a certain dietary regimen, a certain anabolic regimen, or it doesn't. So, yeah, I mean, that's how I guess the connection is made there, but I've never been a competitor myself.
So, Dr. Rand, your practice is you specialize on steroid harm reduction, okay, and on replacement therapy in men. Is what you do? I also do that, but I think you also do this.
Well, I always say the gist of our business is testosterone replacement therapy, yes, but, you know, as part of, and I'm sure you're the same way, once you get a patient in the door, you know, the other practitioners and I love to help you with whatever we can. So it's sort of branched out into regenerative medicine and health optimization. So, for example, yeah, if we can get your testosterone levels up to something that helps solve some of your problems with energy, libido, well-being, and body composition, that's great. But if we can also help you with really any other thing that you're interested in. I mean, if we can lower your blood sugars, let's say, you know, we get a patient and they've got a hemoglobin A1C of 5.6. Well, you know, we'll bring it up. Hey, you know, you say you want to feel better and you want to live longer. Let's talk about ways to lower your average sugar. So again, probably just like you do, we like to branch out to as much as possible in terms of helping patients. We don't see any really sick people. We see people like you who want to get in better shape.
The point is, the majority of your patients, not say clients, come from the bodybuilding community that used to abuse, and then afterwards they face the anabolic steroid-induced hypogonadism and the crash of the HPDA. So some of them are getting into testosterone, but occasionally they would like to add a little bit of exogenous, you know, steroids. So I also follow up their labs for the sake of their vanity, you know, in order to avoid transaminemia, dyslipidemia, insulin resistance, erythrocytosis, the classic standard deviations that happen under AAS use or abuse, of course, yes.
Yeah. Let's not leave out fatty liver, which is one that I learned about a long time ago from Franco Colombo. May he rest in peace. Yeah, and it's fun, and the athletes, or they're not always athletes. I mean, it's a blessing when we get to see athletes, because we're dealing with that top percent. In some ways, it's more difficult, because it's easy to change the life of someone who is, I don't want to say average, but not up at the top 1%, because you've got so much room to improve. When we're dealing with some of the people that we deal with, I'm sure you recognize, Doc, or would agree, it's hard to get, another 0.5% out of that 1% that's left to improve upon. So it makes our job a little more difficult, but it's a lot of fun, right?
Yeah.
Doctor, I have a question for you. Hormone replacement therapy. I don't know how long. I'm curious as to when you started getting involved in providing that service, and how the attitudes that you've seen in our culture, our society, have shifted. Because I know years ago there was such a stigma around it, it was looked down on as vanity. I talked about this with Dr. Thomas O'Connor many times. We have an attitude that men aren't supposed to look good and feel good into their middle age and elderly years. They're supposed to age gracefully and decline physically, mentally, and all that. And it seems like we're finally, last few years, I've seen a real shift. What's the timeline been for you? How long ago did you start doing all this?
Well, as soon as I started practice, I did this. Now, I started later in life. I started this path when I was, I think, 37 years old. So I was an older candidate, and I knew what I wanted to do, once I got started. But boy, your question, I hope, at least before I die, somewhere, even if it's just on my deathbed, I get the answer to those questions that you asked. The main one being, what's the big deal? Why was it poo-pooed for so long? I mean, you could ask that about so many different things in history. Why did so many people follow Hitler for so long? I don't know. It's crazy, because, I joke all the time, it's natural to get sick and die one day. So why do we focus on, things that are only natural? We've tackled bacterial infections with antibiotics. Why wouldn't we tackle what might be referred to as a facet of aging with testosterone replacement? We've got studies that go back as far as the 1950s showing efficacy, not just with men, by the way, with women too, in the 1950s. And then something happened where, it became a stigma. And, whether it's guys or gals, I guess gals were permitted to do things that improve upon their looks and vanity, as you put it, but guys are not. Look, it's always nice to have the benefit of looking better and feeling better, but certainly from a medical standpoint, we've proven time and time again that functionally we're better with testosterone than we are without it. So I hope we get the answer to your question. I have no idea. Doc, do you have any speculation as to why?
Yeah, you mentioned before about insulin resistance. Now, we have to know that as hormones decline after the 40s and we hit the andropause, either you abuse steroids in the past or not, we age because our hormones decline. And the basis of anti-aging, the half of it, the 50%, is replacement therapy of hormones, and not just testosterone, but a whole variety of steroid hormones. And aging is associated with muscle wasting that leads to visceral fat, that leads to insulin resistance and dyslipidemia. So it's a circle. And in the near future, the diabetic assessment has to be evaluated also by HPDA evaluation. So low testosterone, when a hypogonadal man becomes eugonadal with testosterone, improves his insulin sensitivity. So diabetes type 2 can be reversed just by using testosterone, exercise, and diet, and without metformin, for instance, But this is what the big pharma doesn't like. Just a very cheap drug that is demonized out of the bodybuilding and using community. It kills all this, the major incomes also. Testosterone releases nitric oxide that can work as a Viagra, for instance, or it can improve dyslipidemia. So it fights statins. It's crazy. So it's the miraculous drug, testosterone.
I couldn't agree more. I hate to go into conspiracy theories, but certainly, I mean, in terms of just the business aspect, without it being conspiracy, if there's no, I mean, we've seen this with so many things. If there's no drive financially, then things fall by the wayside. And then not to segue too much, Doc, but this has been a burning question for me for so long, and I'm finally going to do something about it, over here in the States. I mentioned Dr. Franco Colombo earlier, and one of the first things I learned from him was, first of all, how we get a lot of fatty liver cases, particularly in the old school of bodybuilding, when you worked out hard, you took a lot of rest between sets, you didn't do much cardio, and it was all about getting bulky, right? Getting size. And so you worked out, you ate a lot, you rested a lot. And they knew back then that typically when you did an anabolic cycle, you'd end up with a fatty liver. And so they always used some methylators, choline and inositol back then, and then they added L-methionine. That's a perfect example. In this country, we have 100 million people estimated to have fatty liver disease for whatever reason. And yet something as simple as 2 B vitamins and an amino acid. Tell me, Doc, have you seen in your practice?
Choline and inositol, the lipotropic factors that they cleanse the liver. Right. And especially now, these fat deposits, it's actually liver glycogen that is stored and not being utilized, So it's like the foie gras that you eat.
Right. Not a big fan of foie gras. Maybe that's why. But to your point, why isn't that made more popular? I don't think it's conspiracy so much as no drug company or any company really is going to say, hey, we're going to make millions of dollars here and cure fatty liver, because there's no money in 2 B vitamins and amino acid. But you would think more of the medical community would pick up on it, though, and say, hey, this is what we got to do. Have you seen, I'm sure you've used it, haven't you seen great results with the use of what we call MCAPs?
I recommend it also, but metformin also helps with that.
Sure.
Now, back to what I said. Think about, before EPO was synthesized, they used to use steroids for the treatment of anemia. Also, for osteoporosis, nandrolone, or even testosterone, they improve the calcium reabsorption in the kidneys. So we have more implementation of testosterone in several other diseases. And this is what the medical society is freaking out about, And they demonize this as a steroid. Actually, testosterone is an androgen, and a man cannot live without testosterone if there's a deficiency of this. We can live without steroids, but as women cannot live without estrogens, we cannot survive without androgens. We are beta males, So in order to reverse the aging, we need to replace testosterone. The point is not abuse it, but optimize it.
I couldn't agree more. And certainly we're moving in the right direction now. When that shift occurred, I can't say for sure, but one of my heroes is Dr. Larry Lipschultz, who is the head of urology at Baylor University. And, I can't speak for the rest of the urologists in the country, but certainly Baylor, under his guidance, has turned out some of the best urologists who are savvy and definitely proponents of testosterone replacement therapy and even anabolics. And we have had discussions about how, yes, you can use it to treat diabetes by improving insulin sensitivity. Baylor even did a study with low-dose nandrolone where it helped, I say low dose to be specific, 100 milligrams a week of nandrolone combined with the TRT to help reduce joint pain. Now, and they published the paper. I can send it to you if you don't have a copy. But I mean, things like that, I think we would all agree, especially our generation, are considered leading edge. And I think that is leading the change in the right direction, because you've got a great university, a great group of doctors now. A lot of fellows came out of that program that are now using this in urology practices, and I think that's gonna make it stick.
Also, Ron had Dr. Mcclain from Harvard in Boston, and he's a major advocate of testosterone, and he it was a demonization about testosterone and the link between prostate cancer. So Mcclain was the first to say, no, this is wrong, and there's no association direct.
I agree. Ron? He deserves kudos for sure. In his book, Testosterone for Life, I think it was, he identified the study, I think, to which you refer. 3 people were in the study, 2 of whom should have been excluded from the study in hindsight because they weren't good candidates. And so our dogma for 70 years was based upon a study of 3, which is not a good study. 2 of them should have been excluded. and I think they referred to methyl testosterone back in the day. I mean, it was just
which is very toxic and very estrogenic.
Right. So you're right. Dr. Morgenthau deserves some credit in turning that around. But so do we've had so many good doctors, and you'll know more some outside the United States than I will, just because.
We have a friend from Italy, Massimo Spattini.
Well, yeah, he's that's right. I met the doc, and he's a perfect example for others and of himself. He sets the tone with his own physique and his own good health. But Dr. Shippen, Dr. Wright. Before Dr. Wright was Dr. Lee. We've got some doctors that along the way have even written books and said, hey guys, this is the way we should do it. But why it's catching on now? I mean, I gave you my best estimate as to why, because it's finally mainstream in the universities and in the practice of urology, rather than just doctors who decide they're going to pick up on it because they think it's the right thing to do. You know what I mean? Like a family practice doctor who realizes, hey, this is good for you. Again, just my theory.
It's there's still so much misinformation out there. I get messages from people, and of course, I don't have any medical training, so I'm not going to answer them. But they're concerned that TRT, just going on TRT, is going to pose a risk to their health. And I don't know really how to answer them the way you two would, obviously, but there still is that misconception out there that even using a replacement dose weekly as a male would lead to severe health problems down the line.
We see it all the time. And honestly, these doc, this is my worst nightmare. I don't want to speak for you, but when you've got a patient that just comes in and, okay, they've read some Dr. Google stuff.
Dr. Google.
That's enough of an issue where you got to sort of back out some of that information or misinformation. But man, when they've come from another physician, or while you're treating them, for example, we've had a couple of patients, whether it's because of a cardiac issue or a clotting issue, okay, have gone to other physicians, which is a smart thing to do. But they come back saying, "Oh, my doc says it's because I'm on testosterone." And you can look at the studies. Let's pick the clotting issue, and that's one that a lot of patients come in having read things on Dr. Google, and they say, "Well, am I at increased risk of stroke?" There are two strong studies out there, and the short of it is, whether it's 6 months or 9 months, the studies show if you have a pre-existing condition, a coagulopathy issue to begin with, then your risk when you go on TRT increases slightly above the norm for that 6 or 9 months, depending on which study, but then it returns to normal. Okay. Mm-hmm. And so, you got patients that have been on this stuff for 3, 4, 8 years, and their docs tell them, "Oh, you got a DVT because of, TRT, not because you've been sitting around for the last year on your duff because of COVID." Oh, that would be another concept, right? So that those are the ones you have to struggle with the most, in my opinion, when you're dealing with fellow doctors that, and I don't mean this in a mean way, but that are frankly ignorant. And we're not expected to know each other's craft. I mean, but at least have some deference and say, well, I got a call this morning from a cardiologist. I love that. Okay. Why don't we do that more instead of just saying, oh, it's got to be the TRT? Because when you get on the phone with somebody like that and you ask them about it, 99 times out of 100, they don't know what they're talking about. That's our specialty, right? And yet they're talking like that to a patient. I don't understand that. Anyway, that's my biggest frustration as other doctors, and that's going to change, I think, as again more and more studies are published. And I say that, and I catch myself, Doc, what is your estimation as to how many studies you've already seen that confirm that TRT is safe and effective? Just to put it simply.
It is safely. Now, the two major concerns is, of course, cardiovascular disease that we discussed this in your show 2 years ago, and also the prostate cancer that has been debunked. Actually, estrogens are responsible for the proliferation of the prostatic tissue as well, because also we have to know that in low testosterone hypogonadal men, prostate cancer occurs. So this is a fact. Now, about cardiovascular disease, the major links would be excessive hemoglobin that leads to perhaps coagulation, but the point is to have low platelets in first place. And second is the excessive estrogens that could be pre-thrombotic. Okay. Now, as far as I know, testosterone improves nitric oxide synthesis and vasodilation of the coronary arteries. It improves dyslipidemia, okay, out of burning the visceral fat. and improves contractility of the myocardium because it optimizes calcium, magnesium, which are the electrolytes. So the heart pumps more efficiently. And as I said, deep venous thrombus is also related to homocysteine levels, to stasis, it means lack of physical activity, okay? And it's multifactorial, and as you said, it's also genetic predisposition. If you smoke, also nicotine leads to platelets aggregation, okay? So it's multifactorial.
But in opposition to those, few studies that might suggest otherwise, we've got just mounds and mounds of research that show the opposite, that what we've known forever, that it's good for you. I say forever, at least since the 1950s. So, that's what we're fighting less and less of as time goes on, thankfully. And I hope in our lifetime, Doc, you're probably an optimist too. I think you're going to see the anti-aging experts anyway prescribing not just testosterone replacement, but for someone who's maybe 75 years old and not necessarily cachexic, but not in the best of condition, an anabolic steroid cycle, maybe annually. It'll all depend upon the factors, but because what's a significant cause of death in the elderly that are weak like that? Falling down the stairs, breaking a hip.
Yeah, disabled.
Days they're dead in the hospital, right? Of some iatrogenically caused, typically disease. So why not make them stronger? So I think it's going to reverse on us, to take your question in further. I think we're going to go from, oh boy, big stigma, to wow, we're going to start prescribing this stuff for health and preventive health in the future.
And
right?
Actually, low testosterone is associated with cardiovascular disease because it leads to diabetes and metabolic syndrome. That's our major factors for cardiovascular disease.
Yeah.
So what you said, yes, we can add a little bit of nandrolone into the regimen of testosterone, and also some DHEA, and perhaps some GH secretagogues or GH itself, in order to reverse aging, and muscle wasting, which leads to osteoporosis, of course, etc.
Yeah. Dr. Mcclain, I'm just curious about the flip side of this, especially where you're so prominent with Jay Cutler TV and a lot of bodybuilders follow you. Do you find that amongst bodybuilders, there's sort of a universal denial of the potential dangers long-term of steroid abuse, where they want your blessing to use massive amounts of drugs all the time with no repercussions?
Well, I think you're talking about, just being human. I think so many people fall in that category where, you get blinded by ambition, and you're willing to do whatever it is that's necessary. And what was and so you double the dose and hope for the most, right? Remember that old expression? But well, they're not going to get. And I think Doc and I both discourage the abuse. I mean, why? I mean, again, not to pick on guys that do that. There are some that are successful riding that fine line between abuse and not. But I think, and maybe I'm ignorant, but I think that's more the rarity than the norm. I mean, if you look at bodybuilders, and I think that's your question, so I beg your pardon.
Yeah.
Bodybuilders in general, because of the nature of the sport, they're going to be riding closer to that abuse line or above it for sure. But I think the average athlete now is realizing that what is being done in the bodybuilding community, not by everybody, but by certain individuals, and is harmful, is just that. It's harmful and is not necessary. Okay, and this is part of, our frustration is if we can just educate everybody, we won't have to go to that extreme. You can talk to some of the best guys, and I'm sure he won't mind my quoting him, but Charles Glass, who's trained some of the greats forever. We've had the discussion whether it's, the amount of GH that these guys are using or the amount of anabolics. There's a certain point at which that S curve kicks in, right? And there's diminishing returns. And so, the legendary, and that's part of it too. A lot of what we hear about what's going on isn't necessarily true. I know certain bodybuilders, and unless they're all lying to me, they're doing X amount, and you read the magazines and it's 5X. I mean, come on, legends are made on that kind of stuff. And it's probably because, in these underground markets, I don't mean to go too far afield, but the same guys that are selling it to these athletes are the ones recommending the 5X. So there's kind of a conflict of interest there, right? Yeah. But anyway, you don't need that much is what the experts really know. And whether it's, using maximum of say 5 IUs of growth hormone in a bodybuilding setting. I'm not talking about for replacement or for healthy individuals, versus some of the things you hear about 9 IUs twice a day. There's no point. And the experts, guys like Charles Glass, would be the first to tell you that, and they're witnessing this over the years, it's crazy. And there are some guys that still do that, and gals, but I think, again, education is very useful, and it's going to turn a lot of that stuff around.
George?
Yeah, doctor, now about the men's age management, do you have a standard protocol that you suggest and you prescribe to your male patients? So apart from testosterone, you recommend them to use DHEA, pregnenolone, for instance, some androgen, some GHRHs. So is it something standard, or do you just go by testosterone itself?
Well, no, I don't always use testosterone by itself, but we here have a bit of a history amongst the laboratory centers, because we draw a lot of blood, so that we can assess all these things.
Some HCG perhaps also, some HCG.
Yeah, no, of course. Well, and okay, so I'll come back to that in a second, and I'd love your opinion on ACG, because anyway, with laboratory assays, we can add to obviously the clinical picture and say, okay, well, you could probably also benefit from some pregnenolone, for example, or certainly some vitamin D, another steroid that people forget is another cholesterol-based hormone, not a vitamin. So it's patient by patient, and yeah, we include anything and everything that we think that will help, that we know we have the ability to adjust. When it comes to HCG, I used to use it only for really basically 2 reasons. 1, cosmetic, to prevent testicular atrophy, and 2, for fertility reasons, right? And then occasionally we noticed that people that, despite bringing their testosterone levels back up from the gutter, they would suffer from low libido. And you go, man, I fixed the testosterone.
Intratesticular testosterone, yes.
And boom, we get a home run, and all of a sudden that was all it took. But now, because of a little bit more study, it's not even referred to anymore as an analog, or some people call it, but it's a homolog. It's so close in nature to LH. And in studies of the brain, we realize we have receptors outside, but also in the brain, called LHCG receptors. So for nerve purposes, okay, I'm now considering using HCG just to, just like we would say, okay, there's a good range for pregnenolone, there's a good range for DHEA. Since we know that on TRT you're likely not going to be producing any LH,
so it helps with the cascade, with the steroidogenesis.
Right. So it's a good idea to supplement even just a modicum of HCG throughout. And I think more studies will need to be done. But it's a good theory to start with, don't you think?
Absolutely, yes. Because testosterone will shut off all the steroidogenesis from cholesterol to testosterone. So HCG, it's supposed to improve pregnenolone, progesterone, DHEA synthesis, and etc. Now, another thing, what is your opinion about, there's a massive anti-aromatase inhibitors wave, and a propaganda against estrogens. Now, as far as I know, estrogens have to be optimized, of course. The point is, we know how much is low, but we don't know how much is high. So, and also it's according to the ratio between testosterone and estrogens. If you take super high testosterone, there's more likely to have elevated estrogens. The point is to have elevated estrogens with a low testosterone. And we know that if we abuse aromatase inhibitors, we have cracky joints, we have low LDL, we have perhaps some endothelium vasculopathy, bad mood. But I believe there is a neuroprotective role of estrogens. The point is, the other flip side of the coin is, are estrogens pre-thrombotic and also could be responsible for prostate enlargement? These are my 2 major fears about having 3-digital estradiol, for instance.
And here again, I'm right there with you. I believe we need more studies, because 2 things. I think we have 2 extremes. We have the camp that says, oh, you have to really strictly control estrogen. And I would say that I used to lean more in that camp by far. And I would shoot for an estradiol of 15 to 20 picograms per milliliter as a just general guide. And then you've got the other camp that says, don't touch estrogen. And the problem with that is that, then you come into problems with gynecomastia and all kinds of issues that to me are just, I think, more obvious than the other. But then the other issue is, we've just listened to how we just talked about it. We know there's so many different estrogens, at least 25 different types we've identified in the human body, and certain of them are good. Certain of them are bad. Some of the estrogens drive the genes we have prostate cancer. We know that.
Yes.
So I think we're going to find that as we progress, we're going to certainly individual to individual let estrogen levels, and I'm using that in the totality, float a little bit. But I think we're going to start picking them apart. We take out estrone. We get an LCMS of estrone as well as estradiol now. And I know that's not the end all be all because we're still lumping all the estrones as one. But just based upon the fact that we have a 216 alpha hydroxyestrone test, right, as a marker for cancer, I think it's a good start. And of course, we're going to be dependent upon the assays available and the cost of those. But I think that's where we're heading, don't you think, Doc? Based upon what you just said, we're on the same page.
Yeah, sure. I mean, some people claim that this reference range in estrogen refer to men before TRT, that they produce themselves testosterone. But after you inject testosterone, then there's no point following this scale, I've written an article about the benefits of estrogens in bodybuilding, but the point is how much is super high, and and this thing that you mentioned about gynecomastia, yes, it's also estrogen dependent, but it's also dependent on IGF-1, on low DHT, on prolactin, so it's multifactorial as well. Again, as you said, it's too early to know, to have solid answers on that.
Well, I got a question for you, if you don't mind. So I was just talking with Dr. Eugene Shippen over the weekend, and you guys, I say you guys, outside the United States, over there across the pond, don't you have access to DHT as a
yes, profiron, and actually, yes,
we don't have that here.
I know, but you prescribe oxandrolone for this because it's HT derivative. So it's miraculous, the misterolone, because it's not 17 alkylated. I use 50 milligrams all year round, and my HDL is above 40, and my LDL is below 100. So it's not liver toxic. It's not lipid toxic. Also, it has slight antiestrogenic activity and improves cognitive function. Sex drive because it boosts free testosterone, and it costs only $3 in Greece, the 20 pills.
Wow.
It is crazy.
Our frustration here in the States, because, and I won't do it justice as Dr. Shippen did explaining over the weekend, but it seems to me that despite what we preach here in the United States, DHT is not such a bad thing. And in fact, it's a good idea to have, like so many hormones, the right amount, not too much, not too less, for prostate health. And it doesn't convert to an estrogen, but it converts to an estrogen-like substance, which is also healthy, right?
Yeah, it's not a villain, absolutely. I mean, it has pros and cons, and actual testosterone is a prohormone to DHT. DHT is responsible for all the benefits of testosterone, sex drive, and mood. It makes you more of a man, but of course, it gives you hair thinning and prostatic enlargement occasionally, of course. My PSA is below 0.5, for instance. Ron?
Yeah, I'm just curious, Dr. Mcclain, if you could prescribe misterolone proviron to all your TRT patients, do you think that that's something that should necessarily always be prescribed?
No, well, first of all, anytime you say always,
yeah, that's a bad one. Most of the time.
Oh, almost always, I should say. The answer is going to be no, but it depends upon the patient. I mean, one of the things we get in trouble with is generalizing too much and using math, which we should in medicine, to describe the average, which is a fantasy. There's no average person. The average is a number. But I think it's placed from what I'm reading now and learning more and more about from guys who've been doing this longer than I have, like Dr. Shippen and Dr. Lipschultz and others, is that we should look into it. Again, the reason why it's considered contraband here, or not something we can prescribe, I don't know the rationale behind it, but it sounds to me like it's something we should consider in certain patients. Particularly, I mean, for example, I don't know how much you deal with post-finasteride syndrome, doc, but it seems to me that would be an easy first step for someone who's been affected by any of these 5-alpha reductase inhibitors, because it seems like that's the obvious of what's been affected. Try to supplement with DHT and see if we can get some of their libido and good mood. I mean, what post-finasteride syndrome affects libido and depression, right?
Absolutely, yes. The mood, yeah, the self-esteem, the self-confidence, yes.
Yeah.
Yeah, they feel crappy. I mean, there was a patient, actually 2 patients of mine that came over to my office almost crying, devastated, and told me, please give me give me my penis back and take my hair that I grow through finasteride. Because the dermatologist 1 year ago didn't tell him the side effects about the lousy libido and sex drive that will be the outcome of finasteride use, you know?
Yeah. The most criminal cases are the ones where, I mean, because in my practice, which is not, you know, it's not huge by any stretch, but when I have a patient who's, say, 45 years old and they try a trial of finasteride, and then within a week they go, oh, doc, you took away my mojo and the wheels fall off the wagon. We pull them off, and within a couple, 3 weeks after that, everything's restored and we don't have an issue. I have 2 patients that were prescribed finasteride when they were young by their, I don't know if it was dermatologist or just a general practitioner, but to protect their hair. And when I say young, I want to say at 16 years old, another at 19, you know, prior to the development of the HPA access, you know, fully developed. I think we still estimated around age 26. And that has been permanent.
Oh.
And I think that's where, you know, there's no question that should be a definite line drawn in the sand. You know, I'm a registered libertarian. If someone wants to take a 5-alpha reductase inhibitor, it's up to them. As long as we firmly believe it's not gonna do harm, certainly to anybody else, but them presumably too. But we should have a strict rule about, you know, under 26 or whatever age, you don't get to even try finasteride. Do you agree, Doc?
Yes, and you know, as we block the one metabolizer of testosterone, which is DHT, we increase the other, the estrogen. So you're going to get some gyno by abusing finasteride, you know. And actually, as Dr. Hertog says in Belgium, those patients that they take finasteride for the sake of the prostatic enlargement due to PSA, after 6 months, they notice an elevation in prostate tissue out of the estrogens that are elevated by the 5-alpha reductase inhibitor block. So by the use of finasteride. And another thing is, I want to say that alternatively, we may use localized application of solution of finasteride and taking some minoxidil or ketoconazole shampoo, perhaps, you know? So in order to avoid the systemic circulation of finasteride per us, instead of applied localized for hair thinning.
That's my argument too, because you'll absorb 15 to 20 times less through the scalp, right? But the argument that I've heard is that it will still oftentimes reduce the serum DHT. And I say, my response is, okay, well, serum DHT is one thing, but you know, cellular DHT is another. It's still a significant reduction, and you're getting the benefit for the hair, which is what most people want, without that systemic influence. So it's at least a step above the idea of oral finasteride, right, or dutasteride.
Dutasteride cross-phase you literally, you know, it blocks the 2 receptors, 1 and 2 in the prostate, in the scalp. But what is interesting, I read in Hertog's book, is that by taking testosterone finasteride, we block the DHT reduction to the scalp, but testosterone thickens the hair. We know that we grow in the chest and in the shoulders. So by blocking the DHT reduction of testosterone, and by using also testosterone along with finasteride, we ensure that the remaining hair becomes thicker. And of course, we know that proviron is not affected by finasteride and all the DHT, just testosterone. So Winstrol, Anavar, and Primobolan, Master, and Proviron are not touched by finasteride, but only testosterone. So somebody that has hair thinning and uses TRT, he should use finasteride, but not Proviron alongside, because Proviron will do the harm, will do the hair thinning, and there's no protection out of finasteride use. But testosterone and finasteride is better than using finasteride alone for the sake of hair thinning.
Have you tried using progesterone? I know it's very, very mild in effect to try and steal away some of the 5-alpha reductase.
No, John Chrysler used to tell that progesterone is good for the also spironolactone. It has mild androgenic activity, especially in females, that may help with hair thinning.
Yeah, but then you got the athletes. You're gonna dehydrate them. I stopped using spironolactone a long time ago because there's just too many side effects that we wouldn't want.
It acts against hirsutism in women.
Yeah, no, absolutely. Yeah, it works well. I haven't seen it work well in men, but I've seen it work well in females for sure, right?
It can give you a little bit of gyno because it disrupts the receptors of the androgen receptors in the mammary gland, I guess. So it has some side effects of gynecomastia and the prolonged abuse, of course, elevated potassium that could be fatal,
Right.
Interesting. Wow. So finasteride, just one quick question. Finasteride, we hear about post-finasteride syndrome, but are most of the side effects while you're using finasteride, or do you experience most of them when you cease the use of finasteride?
Well, in my experience, certainly while you're on finasteride, you see the effects in those that are susceptible to them. It's not a large percentage. Most people that I see, they go on finasteride and they don't have an issue. But the concept of post-finasteride syndrome is that even once you stop prescribing them, once they stop taking it, they still suffer effects, and that's a disaster.
This is what Chris also said. But I have a patient who's a surgeon. He's a colleague of mine. He's a doctor. And because he's genetically predisposed, his father and his grandfather were bald also. He's been using 1 milligram of finasteride 20 years in a row. And he saved his hair, of course, but he told me, if I stop finasteride, I'm going to have a hair thinning occipital here and eventually baldness. And now he was introduced into replacement therapy because he's been cycling on and off for a couple of years. And he told me that as long as he started using testosterone along with finasteride, the hair that he had became thicker, So it's what I said before. So testosterone strengthens the hair and makes them thicker as long as you block the DHT by finasteride. But the combo is miraculous.
Good to know.
And you use the topical formulation sometimes?
Yeah, I suggest it. Myself, no, because I don't have hair thinning issues. But I suggested yes. So it's a foam that has minoxidil, and perhaps we can apply some dutasteride in a foam, And I tell them to wash them herbs with ketoconazole, which is shampoo, and afterwards they apply the foam, And they told me they don't experience these libido, sex drive issues and moodiness, as they were taking from the mouth orally the finasteride. But of course we use low dose, 1 milligram or 0.5 milligram. The Propecia pill is 5 milligrams for the prostate.
Right. Do you have access to a prostaglandin analog called latanoprost, which they normally use ocularly? Because we found that works great for way better than minoxidil as a topical application. They've used a similar structured prostaglandin analog for Latisse, Allergan, for the eyelashes. But latanoprost, I think, works as well or better alongside. You can use it by itself or with a little bit of finasteride topically. I was just wondering if you guys can get that in Greece or not.
No, but we have a cream that is applied in order to fight acne. We know acne is related to DHT. And actually, this cream is capable of lowering DHT in the scalp, in the epidermis. And it's azelaic acid, actually.
Azelaic acid, yeah.
It burns a lot, but it's so damn effective. I've been using this since I was in medical school, I was stressed out by girls and I had some acne. So, so it's miraculous, and it kills the DHT in the epidermis.
Wow.
Yeah.
Dr. Mcclain, did you say that drug you were just referring to is administered ocularly? Does that mean it's in eye drops?
I'm sorry. That's what its original use was in ophthalmology.
Wow.
And a guy named Robert Nettles, I believe he's responsible for first discovering that it made the eyelashes grow. So they used this latanoprost in the dropper, right, in the eyes, and he noticed that the eyelashes were growing. And I think he got a patent or some sort of business deal with it. but never solidified anything with Allergan. And I think, time passed and Allergan said, okay, we're just going to find another one. I forget the name of the prostaglandin analog they have in Latisse. It starts with a B, but, and I don't want to say it's inferior or not. I can tell you that for sure, latanoprost here in this country can be obtained by a compounder, and it's much cheaper than the Latisse, which again, they use it, they market it strictly for the eyelashes, but it works fantastically alone or in combination with finasteride or ketoconazole or azelaic acid to help with hair loss. And again, topically, so you don't have to worry about ingesting all that and affecting yourself systemically. It's a great product we have here.
Yeah, my wife uses that for her eyelashes, Latisse. Yeah.
Yeah.
Ron, when an Olympia competitor, let's say a RFB Pro that competes, approaches you for the sake of his labs, now when you face dyslipidemia and elevation of LDL cholesterol and reduction of HDL and elevation of alpha-homocysteine, do you recommend statin use, or alternatively you may apply some other agents like red rice yeast, polycosanol, phytosterols, bergamot, so that they don't have the nasty effects of statins, because there is also an anti-statin wave out of the side effects that lead to in the muscles, in the liver. They induce also insulin resistance, they lower Q10 in the myocardium. So of course, it's the holy grail of cardiology, and they prescribe it even if you have 210 cholesterol. But the point is, if you train seriously, then you may feel extremely sore that will affect your liver, perhaps. So what's your take about statin prescriptions?
That's a big one. I mean, I've seen everything that you talk about. I have a friend of mine I've known for 40 plus years who was recently put on a statin by his primary care physician and suffered all the side effects. Actually, he said he did okay when he was working out, but afterwards he was devastated. And as you said, it leaches your CoQ10. So the first thing I told him was, hey, try adding some CoQ10 to your diet. And for some people that works, some people it doesn't. But we go back. I mean, to start from the beginning, I would say in this country anyway, even the cardiologists are still subject to a lot of the dogma regarding lipids and their effect on the vasculature. We now know, guys like Mark Penn, who used to work with Cleveland Clinic and other top cardiologists, know that it's really more a factor of inflammation driving all of this in terms of plaque buildup, and having the fuel for the fire. That spark is fueled by the elevated, the so-called bad cholesterol, the LDL cholesterol. But to put it in short terms, if you've got established coronary artery disease, then yeah, I would consider a statin. Or to your point, I like starting with red yeast rice because it's got 12 of the monocolins that are used, one of which is used, for example, for lovastatin. And it seems like, and correct me if I'm this differs from your experience, but when you go directly to the plant from which the drug is made, oftentimes you have fewer side effects if you can extract that ingredient along with the rest of the plant in whole, than if you take out the individual parts like they do for example lovastatin, and get the side effects therefrom. So I'll start them off with red yeast rice if it's appropriate. But like I say, I'll tell patients, first of all, you need cholesterol. Again, to your point, okay? You can't just get rid of all cholesterol. You shouldn't. I mean, we have some advantage with patients that are TRT patients because we're supplementing those hormones made from cholesterol. But what about a younger patient that's not on TRT? What are they going to? We're going to create a TRT patient, right? So I say, look, I use the analogy just like a 5-gallon gasoline can in your garage. You need that gasoline to run your lawnmower, right? So you can clip the lawn. It's not a bad thing per se. It'll be bad if you use it right next to your acetylene torch because you might blow up the garage and half the house. But otherwise, it's a good thing. And so just like you wouldn't give an antibiotic to someone necessarily unless they had an infection, a bacterial infection, why would you give a statin to someone unless you've shown that they have established coronary artery disease? Now, you can go into risk factors and all that kind of stuff and trying to nip it in the bud. But I'm talking about your average patient who doesn't have a first-degree relative, with issues or anything like that. So I'm not against statins. I joke all the time. The web page that says that statins don't work to slow, stop, or reverse coronary artery disease is right next to the one that says that we haven't landed on the moon and no Jews were killed by Nazis in World War II. it definitely works, but when do we use it? I think is the point you're talking about. There's a place to use it, and not in this country. Typically, what they do, typically, the 95% of the medical population will see elevated lipids, and they'll say, "Okay, patient, you have 90 days to clean up your act. You do it with diet and exercise, and come back in 90 days. If not, I'm going to give you a statin." Or they write for the statin right off the bat. To me, that's crazy. It doesn't address the source of it all, which is inflammation. And we go back to some of your points earlier, having, insulin insensitivity, all the things that drive inflammation, we ought to be addressing first and foremost before we start addressing cholesterol, which I don't know if the fat is there in Greece or not, but we've got ketogenic dieters here that come in with LDL cholesterols close to 200 because they're eating so much.
It's saturated in trans, yes.
Yeah. But they're not dropping dead or developing cardiovascular disease like that, right?
Yeah. Wow. Well, guys, we're coming up on an hour. Doctor, do you have one final question, Dr. Touliatos, for Dr. Mcclain?
Well, first of all, I want to thank him again for his precious time, And what are your thoughts on the future of the anti-aging wave? And because in Europe and in Greece, of course, we have this called hormonophobia. They're afraid, they have the fear of hormones, and it's based on ignorance. When you're afraid, it's so easy to demonize. And the wave comes from the West, from the United States. And we know that also women receive testosterone, like Jane Fonda. She looks great at 75. So you believe that this will explore, and the middle-aged men at least will have a second puberty and a chance to live better and get rid of Viagra or SSRIs, because if you have low testosterone, it's most likely to have depression, and SSRIs maybe not be used in first place. And also, if you have low testosterone, you don't need a Viagra, but you need testosterone in order to improve nitric oxide and libido, of course. So you believe things, we have a light in the tunnel, and things will be more positive and optimistic for this decade that we're going through?
I am an eternal optimist. So you're asking the wrong guy if you want a level-headed opinion. But I believe so, George. In all seriousness, the cat's out of the bag. And right now, you already addressed what the issue is. It's ignorance. And so education is so much more easily doled out, if you will, with the internet and the information age, we call it still, I think. So it's just a matter of people learning more and spreading the word. And I think then human nature is going to take over. I see patients that, you could tell, or they've stated 10 years ago, said, I was never going to do anything that wasn't natural, and I would never take something if I didn't have to. But then they suffer enough, unfortunately, and they come in and they say, Doc, whatever it takes, I give, let's try it. And part of me gets where that comes from, because certainly interfering where we shouldn't can cause a lot of problems. What's our number one objective? First, do no harm. But, we are now more educated as a whole, doctors and the population in general, where there's less likelihood of the just sort of willy-nilly ignorant, hurting of and harming of a patient. We have facts and plenty of information supporting TRT and other anti-aging tactics that we can employ now. So yeah, I'm bullish going forward that it's only going to get better from here.
Excellent, cool. Wow, thank you, Joel. That's a great message to end it with, because a lot of us we need that hope, because, like I said, we've seen testosterone demonized, we've seen masculinity more recently called toxic and demonized, and we're hoping that we can all get along and change these attitudes in the years to come. And thanks to doctors like yourselves, you guys are making a tremendous difference. You're educating so many people with your practices and with these videos that we do. So, you guys are definitely part of the solution. So thank you so much, guys.
Well, I know I speak for you, Doc. We're having fun doing it too, right? I couldn't think of a better profession to be in. And thank you guys for having me. I enjoyed this very much. And anytime, it's always a pleasure to discuss anything with you, Doc. And Ron, this is my first time meeting you, but thank you very much.
You're welcome. All right. Well, everybody, thanks for watching. Ask Dr. Testosterone. We'll see you next time.
Ciao.